Very good evening to all present here. On behalf of Vision Science Academy, myself, Kristi Sharma, Education Engagement Manager at Vision Science Academy, welcome you all to our exclusive webinar, the Vision Science Talks. Vision Science Academy is a higher education institution situated in London, United Kingdom, with a global member base of more than 15,000 individuals, increasing even at this moment. At the outset, I request our attendees to keep your microphones and cameras off at all times during the event. Today, we gather to learn and enrich our minds with an often overlooked aspect of Parkinson's disease, how this neurodegenerative disorder affects vision and ocular health. Globally, an estimated 10 million people live with Parkinson's disease. Although a wide number of people are aware of the motor disabilities associated with this condition, a lesser focused aspect is the ocular changes that happen as a result of this, and how addressing these changes can be an important management in these patients. Whether you are a healthcare provider, a caregiver, or someone curious about this topic, I hope you will leave today with new insights into how Parkinson's affects more than just body movement. Without wasting any more of our time, let us welcome our esteemed speaker for the day, an expert who has studied and published her work on Parkinson's disease and eye. Ms. Ayisha Atiya, an optometrist with over 11 years of experience, specializes in binocular vision and neurooptometry. She holds degrees from the Elite School of Optometry and a fellowship in neurooptometry from Shankar Nethralaya, Chennai, a fellow of the American Academy of Optometry and associate fellow of the Higher Education Academy. She has taught and published extensively in her field. Currently pursuing a PhD at the University of New South Wales, her research focuses on amblyopia, visual rehabilitation, and neurooptometry. She also serves as a casual academic, contributing to teaching and research in binocular vision and visual assessment in acquired brain injury. A gentle reminder here for our audience, if you have any questions for our speaker today, put them in the chat box and they will be addressed during the Q&A session. A warm welcome, Ms. Ayisha. Over to you.
Thank you, Kristi, for the wonderful introduction. Hi, good evening, everyone. Just give me a couple of minutes to share this. Is my screen visible?
Yes, it is visible.
Shall we start? Or should we wait for the participants?
We can start.
Okay. Thank you. So, hi, good evening, everyone. As Kristi mentioned, I've finished my fellowship in neurooptometry, and I have over clinical experience of 11 years, where 5 years experience in neurooptometry. And I'm here today to give a talk on ocular implications of Parkinson's disease. So I'm currently doing my PhD in vision science at University of New South Wales, Sydney. Thank you everyone for joining here. So today I'll be covering like what happens in Parkinson's disease, what are the visual and ocular symptoms, why is it important, what are the common ocular features in Parkinson's, the detailed neurooptometric assessment, management, and a case discussion. So I wanted to keep it interactive, so I request everyone to join the menti.com. You can just Google it, menti.com, and use the specified code. So you can join in and probably I'll present the questions accordingly. So please keep this accessible because you will often revisit it during this presentation. I'll give a couple of minutes for the participants to respond. I just want to know what is the strength of the participant and probably what is the current role such that I can go about. Here we have a mixture of clinical optometrist, undergraduate students, and academician. So I'll keep it simple. So if you're done with the first question, here's the next question. How is your knowledge in neurooptometry? It ranges from nil, minimal, good. Great. People have good knowledge in neurooptometry. That's great to see. Okay. It will be easy for everyone to understand my language. We'll move back to the presentation. Okay. So what happens in Parkinson disease? Parkinson disease is a chronic progressive neurodegenerative movement disorder. It ranges from like being a neurodegenerative disorder. It can have various causes like because of the oxidative stress, neuroinflammation, mitochondrial dysfunctions. But mainly it is characterized by the progressive loss of the dopamine producing neurons in the substantia nigra and the accumulation of the alpha cyclic in Lewy bodies. So it primarily affects the motor neurosystem, which is often accompanied by tremors, muscle rigidity, bradykinesia, which is trouble initiating the movements, postural instability, and gait disturbances, which in turn has en bloc turns, like the patient is not able to, I mean, they use the head and body movements more rather than just moving their body alone. And it's also accompanied by the sensory symptoms, numbness, burning, and pain. So it affects 1 to 2% of the general population, which is about 65 years. And precipitating factors range from age, male gender, genetic, and environmental factors. So I request you to join in Mentimeter again. For the next question. The question is, what is the main visual problem you have come across in Parkinson's? You need to type the response. I'll give a couple of minutes to get in. Eye movement restriction, diplopia, double vision. Great. Reading difficulty. I'll wait for a couple of responses to pop in. Most of them say eye movement restriction and diplopia. Anything more about visual? Reduced contrast sensitivity, blurred vision. Great. Coming up. Okay, wonderful. So it seems like there's a quite good knowledge on it. So moving back to the presentation. So visual symptoms range from blurred vision, visual fatigue, difficulty reading, reduced depth perception, decreased contrast sensitivity, difficulty with color perception, light sensitivity. So all these problems occur due to the level drop of the dopamine. So basically, the depth perception is impaired when there is some pathology in the parietal regions, and due to the low levels of the dopamine, all the reduced visual symptoms like decreased contrast sensitivity, visual fatigue, and when there is a decrease in contrast sensitivity, the patient tend to have visual glare, and while driving, and has difficulty in seeing dim lights, and most of the color perception is due to the differentiation in difficulty, differentiating dark green, light blue, dark red, sensitive issues here. So light sensitive is more of it can be a pupil involving one when there is increased in pupil size, and sometimes it is due to dry eyes too. So visual perceptual issues can have range to visual hallucination. So visual hallucination is one of the chronic and most complicated symptom of Parkinson disease, because especially in when the Parkinson patients take medications like levodopa and dopamine agonist, they tend to have increased levels of dopamine, which sometimes it's out of control, because the levodopa is given to improve the motor issues, but sometimes it's overdose, and it might end up in issues with thinking and perceptual issues. And in cases of longer duration of Parkinson disease and poor vision, reduced activity of the primary visual cortex, and visual spatial orientation is nothing but having an issue differentiating the distance between the objects. When the basal ganglion dysfunction occurs, there is a problem in coordination of the movement and sensory information. So that's when there is a issues when spatial orientations, and it sometimes become very difficult that it also leads with cognitive issues like visual memory and slowing down of all processing. So again, we go back to the Mentimeter. So the question is, vision is good. So we saw all the vision complaints. Sometimes even if the vision is good, but the patient is still happy. So what kind of issues you come across when the vision is completely all right, but there is something else lagging behind, which actually is a problem and not manifested at the time of just vision assessment. I did find the answer in the previous question. So that's a clue to actually know what I'm expecting. Apart from vision, dryness, dry eyes, something to deal with neurooptometry. CI, visual processing, light sensitivity, constant fatigue, uncomfortable with specs. Great. Almost there. Thank you for your responses. And switch back to the presentation. So it's like oculomotor difficulties. Okay. So because when the vision is fine, you kind of next level of the understanding and knowing things is to see if there is any oculomotor involvement, and then any other perceptual issues or any other non-oculomotor based issues, basically. So firstly, we have the limitation of oculomotor movements. So when there is to understand limitation of oculomotor movements, you just need to see how the eyes move well. So I'll be dealing with the test how to assess all these things. But to general knowledge about what exactly you have to do is just to find the limitation of the ocular movement test using a broad edge. And next is a diplopia. So convergence insufficiency is a common phenomenon which occurs if you have diplopia initially. So it's nothing but like when the patient is not able to turn not able to converge and move their eyes in to see a close object, basically. So that's when they actually end up in having double vision when it becomes worse. Saccades are sudden eye movements when you shift the gaze from one point to another. And there is a delayed saccadic performance due to slower saccades or sometimes with the initiation of the saccades, basically. Smooth pursuits is a continuous eye movement when you track an object. So when there is a reduced pursuit performance, you get jerky movements, and sometimes the corrective saccades pops in to actually compromise the pursuit performance. Abnormal optokinetic nystagmus is nothing but a rhythmic eye movement, which which happens when you actually see a moving object. For example, when you see a moving train, you need to do a continuous pursuit and then a saccade. So when this happens, there is a combination of a pursuit and a saccade. So both has to happen. Sometimes when there is a decreased saccade or a pursuit performance, this overlaps and gives an abnormal optokinetic nystagmus. And next we have the larger pupil diameter and anisocoria. That is due to the autonomic imbalance of the parasympathetic nervous system. So this is an article mentioning the ocular features in Parkinson's at Neurooptometry Clinic. 43 patients were recruited and mean age of 70 years with the visual complaints of decreased vision associated with reading difficulty, followed by only double vision, followed by decreased vision with double vision, and then the restrictive ocular motor movements. So as you can see, the gaze limitation where the majority people had, and most of them had the vertical gaze issues, limitation of the vertical gaze issues, followed by both vertical and horizontal gaze issues. So here we need to think about more than horizontal, even the vertical component is involved. Next, we have the binocular vision dysfunction, where convergence insufficiency is more, and then combined with the oculomotor dysfunction. But we also have a combination of vertical gaze palsies. So in this point, I would like to emphasize here that when you have a combination of convergence insufficiency, oculomotor dysfunction, and a vertical gaze palsy, convergence insufficiency is treated first, because you need to first treat your horizontal fusional divergence amplitudes to make the eyes coordinate well first, and then deal with vertical gaze palsies or the vertical component basically. Because if you are not treating the horizontal amplitudes, you might end up in double vision and not very much comforting the patient about their complaint, basically. Next, we have the reduced reading speed. And then you have the low developmental eye movement ratio, which ranges from 0.46 to 1.67. I will be dealing with all these tests later on. So just to kind of tell you that it's decreased. So this is a patient showing receded near point of convergence in Parkinson, and this one with reduced near positive fusional divergence amplitudes in Parkinson. So this is another article stating the progression of convergence insufficiency in Parkinson disease. So based on the stages of Parkinson disease, it was actually, the cases were actually classified, and then the distance covetous, near breakpoint, and near positive fusional divergence was done. So as you can see, the blue ones are the case group, that is the Parkinson group, and the orange ones are the control groups. So the blue one is actually increased. So from about it's increased to -10 diopters, that is kind of 10 exophoria. The neophoria is increased, and then the near point of convergence breakpoint is also increased, and the near point of positive fusional divergence breakpoints has actually reduced. But in all, the control group stays stable. So this you can see that in Parkinson's, definitely the convergence insufficiency also plays a major role. And on progression of Parkinson's, convergence insufficiency also progresses. Sorry about that. So ocular disease, there are various ocular disease issues in Parkinson's, ranging from glaucoma, macular degeneration, retinal diabetic retinopathy, because it's more associated with the comorbidities. So that's why it's essential to know if there are any comorbidities. And visual field deficits range from choroidonopias, paracentral scotoma. You can also have retinal and macular nerve fiber layer thinning, and dry eyes, blepharospasm, apraxia. In dry eyes, mostly you have to do the assessment like see the blinking rate, and see the tear film assessment basically. And cataracts are quite normal. So when we have all this visual and oculomotor symptoms and all these issues there, so definitely the quality of life is going to be low. And in this paper, the subscales of general health was more, and definitely near visual activities also play a major role here, because it's much more to do with reading, driving, and peripheral vision also for mobility. So next we'll move on to a neurooptometric approach. So starting from demographics. So demographics, kind of like age, gender, it's one of the risk factors, right? So that's why that's very important to know what is the exact age, and also the gender. Based on the age, we can know whether it is progressing, how it's progressing, and presenting complaint is essential to know, because based on the presenting complaint and visual needs, we need to treat them basically. For example, you need to ask more about the presenting complaints with the associated complaints also. For example, if you have a double vision, so you need to ask whether the patient is having a double vision, basically a monocular one or a binocular one. So when there are monocular diplopia, it's a different entity for treatment, right? So when in monocular diplopia, you kind of see whether they have any refractive errors, or any cataract, or is it because of the decreased contrast sensitivity. The treatment line totally differs for a monocular diplopia, whereas in binocular diplopia, it might be due to the convergence insufficiency, decompensated latent strabismus. So the treatment lies, the underlying treatment lies what is the patient's presenting complaint and the associated symptoms. Medical history and neurological history is a must, because you need to know if there are any other associated comorbidities. Like I told, um, how diabetic retinopathy, acquired brain injury like cerebral strokes, and progressive supranuclear palsies. All these are kind of an added one. If there is already a Parkinson disease history, and and there is an extra brain injury involvement, then the treatment is much more, you have to be very careful with the treatment, because it's going to be progressing more when compared to just only Parkinson. And previous reports like imaging is also important, because you need to know what site of involvement. So for example, if you have a parietal lobe involvement, you have spatial issues, and you have difficulties with orientation. So based on that, you need to actually give your treatment. Medications and previous treatment is very important, like I mentioned, because of the levodopa and the dopamine agonist. You kind of know if there is if there is any involvement because of the medications. So I came across a patient. Initially, we were doing an assessment, and he was not able to concentrate. He was not able to concentrate to look at the gluten stick, which we actually show for the convergence test, because he was having very poor amount of motor issues, motor oculomotility. Then we advised him to take levodopa, take a little bit of rest, and then come back. When they take levodopa, it usually improves the motor ability, but to an extent, we could actually test without any interruption. But again, there are pros and cons of all medications. So when you take levodopa, probably you might end up in, if it is overdosing, you might end up in visual issues also, like visual hallucinations. So all these things are very important when you actually ask them the previous medication, what are the medications they are using, and previous treatments. So, for example, they have been undergone with speech therapy, physiotherapy. So if they have already undergone, they might have already had a protocol of what they have done, and they might not repeat the same protocol. You might refer it to another person who is actually having a added one to what they have already using it. Okay, so occupation and visual needs is very important for me, because based on the occupation and visual needs is what how I decide my treatment basically. So when, for example, if the patient wants to use a system, he's a system user, but I will be explaining in the subsequent slides the glasses to be used. And but you have difficulty, they have difficulty with eye movements, and it's very difficult to give a progressive glasses. So at that point of time, you need to decide what particular glass you need, and for which particular occupation. So next is the screening. So screening test will have a basic vision, which includes the refraction, and then the basic oculomotor test. It's just two tests like the FAAO and NPC. This is quite enough to understand whether there is any underlying binocular vision condition. And then we have the ocular health, like assessing the eyelids, blinking rates. Then we'll move on to a comprehensive oculomotor based test. So like I said, ocular ductions are important. You do a broad hedge test to actually know how the limitation is, or if the movement is full. Then you have the binocular vision testing, the whole binocular vision testing. But I would suggest, because it's above 40, so we have a kit of only Virgin's test here, not the accommodation. So starting with stereopsis, word for dot, the sensory test, and then the cover test with prism bar cover test to see the amount of prisms, near point of convergence, fusional divergence amplitudes, and divergence facility. So then we'll go to the neurooptometric assessment. So I'll be covering how to assess saccades, pursuits, then how to use a developmental eye movement test and reading speed. Reading speed can be done by either using instruments like Readalyzer, or you can just tell the patient to read for a minute and then count the words. It's kind of like below 200 is actually abnormal, but you have to also know whether the patient reads English fluently. So here for a saccade test, yeah. So take a pen, preferably red and a green or two different colors, and the examiner will hold the two targets at 20 centimeters apart, and you just have to tell the patient to look at the target which she's telling. For example, if I tell red, you have to look at the red, and green if I tell green, and then he has to move from left green and right. And based on that, you have to score it based on ability, accuracy, head movement, and the body movement. So you have to do, there is the horizontal saccades as well as vertical saccades done horizontally and vertically. So based on ability is nothing but like how much extent they are able to do. It starts from less than 1 to 5 rounds. So are they able to complete all the 5 rounds, or are they doing it less? And then the accuracy is to see if there is any undershoot or overshoot, and use of head movement or body movements. So 5 is the best score. So anything below 4 is abnormal. Next, you have the pursuits testing. So first you do a clockwise, and then you do an anti-clockwise testing. So each 2 rotations each side, and see how is the ability, then accuracy, are there any refixations, and then the use of head and body movements. So here again, the best score is 5, and below 4 is quite abnormal. Then you also have objective assessments with eye trackers, electroculography, where reaction times, saccadic latencies, and anti-saccade errors are addressed. Then we have the developmental eye movement test. So there will be 4 charts as you see: pre-test, test A, B, and C. Pre-test is just to kind of make the patient understand how you're going to read. Test A and test B are vertical ones, so they just have to read, and you have to count how much, the time basically. And then test C is the horizontal way, and then calculate adjusted horizontal score based on the formula in the slide, and then calculate the ratio, which is nothing but the adjusted horizontal score by the vertical score. So based on this, you kind of grade them into the types. Type 1 is normal performance, where you have all the horizontal time, vertical time, and the ratio is normal. Type 2 is a kind of oculomotor dysfunctions, where there is an increase of horizontal time, but the vertical time is quite normal. Because there's an increase in the horizontal time, there's an increase in the ratio also. And type 3, it's because both the horizontal and the vertical time is increased. There's a normal ratio, but it is more to do with the number issues rather than an oculomotor dysfunction. And type 4, it can be numbered issues or an oculomotor dysfunction, where all the ratio, the horizontal time and vertical time is increased. Then we move on to the non-oculomotor based test. We have the contrast sensitivity with Palirobson, color vision, Ishihara, FM100, visual fields confrontation, Amsler grid, Humphrey, visual processing, and cognition using mini mental state. So managing, you have to first understand what is the refractive correction. Like I said before, prescribing them with single vision is the best option, because you kind of don't want to mix them. They already have motor issues, oculomotor issues. So when you try to give them progressive, it is difficult for them to just shift their gaze from up and down. So single vision is the best. And then prisms. Prisms, you kind of give it when they are seeing a constant double vision. You can either give it as a ground prisms, or if there is any much more larger deviation, you use the Fresnel prism. Initially, you try vision therapy, and then if not possible, so in cases of Parkinson, you have tremors, which is difficult for the patient to actually hold the instrument for vision therapy. In such cases, you can actually give prisms. Most of them end up with prisms because of this issue. And then referral for an ocular disease. You can all, like we have seen before, we have certain patients who also have vertical gaze palsies. There, in such cases, you can give prisms, your prisms, vertical prisms, basically. So this is kind of like summary to make you understand. Like for visual acuity, you kind of give the glasses, and then for ocular surface, test the blinking rate, inspect the eyelids, and for oculomotor dysfunction, you either see whether there's a binocular or monocular diplopia. Based on that, if there is any near point of convergence recency, like in cases of convergence insufficiency, address it with vision therapy. And then optic nerve and retinal issues, do the Amsler grid confrontation, and any visual field deficits, address it and address it accordingly. So move to a case discussion wherein this is a 40-year-old female having a complaint of losing track while reading and difficulty performing tasks in dim illumination. Parkinson for 1 year, has a mild tremor, bradykinesia, and slurring of speech. Physiotherapy and on speech therapy and normal vision. Okay, so this is the oculomotor evaluation of the patient. So I request you to go back to the Mentimeter and say me what exactly is the problem with this patient. What can be the tentative diagnosis, or you can actually tell me what is the reduced component, what is the problem, what is the issue, also you can tell me. I will wait for a couple of responses before I prompt what is the answer. Reduced NPC. Is it reduced NPC? Is the near point of convergence reduced or receded? Was cards. Great. Receded NPC with both accommodative target and the red-green target. Great. I did get some responses like CI, convergence insufficiency, oculomotor dysfunction, poor reading speed, receded NPC with both. Good. I think that finishes my Menti. I'll go back to my slides. So we see a greater exophoria, 8 exophoria, NPCs receded, low reading rate, poor cards, poor pursuits, and the DM score is also increased. And both vertical and the horizontal time is increased. So this patient was given home vision therapy and followed up after 6 months. So next we have the orthoptic treatment with CI in Parkinson disease. It's a case series, but they could actually take only 2 patients for follow-up. So this is a CI specific OT program, which had a duration of 8 weeks. And they gave 3 home-based exercises, pencil push-up, Broxting, and variable vectogram, like for 5 days a week, 3 times 10 minutes. They specified 2 minutes of pencil push-up, 3 minutes of Broxting, and 5 minutes of variable vectograms. So first one was a case of a 68-year-old. Both were male, sorry. And first one had a Parkinson of 6 years, had a multi-morbidity, complaint was uncomfortable while reading, but the other one had Parkinson for 5 years, and the complaint was left eye goes away while reading. Both kind of similar complaints. And they had, case one had a receded NPC, lower positive visual divergence amplitudes, and a greater CSS score. And both of them improved after treatment, basically. But since I would suggest first going into a in-office therapy, training the patient how to do the test, how to do the vision therapy, because you might end up, you might not know how the patient responds to the home-based vision therapy. So probably a couple of sessions in office is recommended when you actually want the patient to do a home vision therapy. And then the case one was followed up for 2 months, and a phone call after 3 months was done to do the CISS score. And both the cases improved after the follow-up. So to summarize, my take-home message will be Parkinson disease presents with visual and oculomotor deficits. A detailed history is very important to know what is the visual need and what exactly is the problem of the patient. And based on the problem of the patient, you kind of carry out the comprehensive neurooptometric assessment and then manage them based on their visual needs. Thank you. Hope I completed on time.
Yeah, we were perfectly on time.
Thank you.
This had been a very interesting and insightful presentation. Thank you so much, Ms. Ayisha, for sharing in-depth, so invaluable information regarding Parkinson's disease. and how it affects the human eyes. I believe this talk will encourage more professionals and students attending this today to come up and gain necessary skills to attend to and manage Parkinson's disease, as well as the various other neurodegenerative conditions. I open the floor now for the Q&A session. So if you have any questions for our speaker today, you can drop it in our chat box. Until then, we have some pre-recorded questions as well. So we have one question that we got during the registration process. What is the end stage of Parkinson's disease?
There are various stages of Parkinson disease. You have various scales measuring it. But when you want to see pertaining to the treatment, basically, it depends on the patient. If the patient is able to actually undergo the treatment in a very good way, then you can actually give the treatment based on the stages. It's not that you have to give patient. You cannot give treatment for severe stage of Parkinson's.
So our second question was how to grossly identify a child with Parkinson's disease or with least symptoms during rural eye camp or large screening for easy referral.
So basically, I've never seen Parkinson in children. The prevalence also states that it's more in adults, and it's more in, it starts from 55 basically, and then it moves on till 85 also. It's more like a neurodegenerative issue rather than any acquired one. So it does not occur mostly in children. So to answer the first part, the second part was?
Like for grossly screening in a large setup, like a screening camp or a rural camp. That was
Yeah, so I've specified that in the slides. Basically, you just have to check the vision. So they might have visual issues and oculomotor issues and some perceptual issues, basically. So this is what we can, yeah, to an optometry setup can be, optometrists can address these kind of issues. So when there is any vision issues, and using the cover test, you can easily address the FAAO and the receded NPC. You can know whether they are actually landing up in any convergence issues and any perceptual issues. Basically, history is very important. So the detailed history, if you take, you kind of understand where the patient stands. And test, you just have to do a couple of oculomotor tests, which can actually know how you're doing it. I mean, how it ends up in diagnosing the neurooptometric issues.
Okay. So we have a third question here. Given the chronic nature of Parkinson's disease, how often do patients have to repeat vision therapy, or is there a time when it is not fully effective?
Yeah, in Parkinson disease, it's definitely a challenging one because it doesn't improve just like the uh, normal aged ones, basically. So for Parkinson disease, you just need to give them time. So initially, like how I described in the cases, you can do a vision therapy protocol, but to make them understand what they have to do it in home. Home therapy is the best because it's not going to improve overnight. So you need to actually give them for about a couple of months or probably 3 to 4 months. So you can give home therapy, but before giving home therapy, just try to give some couple of sessions in office to make them understand what they actually have to do. So probably 5 sessions or 2, 3 sessions at least, if they are not able to actually come frequently, just give them a couple of sessions and then you start over to do in home therapy. Sometimes what happens, they will not have that much motor control to start off initially with straight directly with vision therapy. So in such cases, start with prisms and vision therapy as a combination, and then improve them to a level where they can actually do vision therapy alone and then leave it to home therapy. For the follow-up, you can follow up after 3 to 4 months, basically, because it's not going to improve overnight. So give them some time to actually do the vision therapy, understand it better, and then initial day by day, they will improve their symptoms also while reading and while looking around, while reading things. So call the patient, keep a track what they are doing, and then probably give a follow up after 3 to 4 months.
Okay. So our next question is, how can Parkinson's disease affect eye movements and visual processing?
Sorry, I didn't hear you.
Yeah. How can Parkinson's disease affect eye movements and visual processing?
Eye movements, basically, they have issues with convergence, saccadic issues, pursuits issues, like I've specified. Visual perception is much more like spatial orientation, and like you have much, the major one is like visual hallucinations, and you can come across visual memory issues because it's neurodegenerative also.
Okay. So I hope that answers their questions. Our next question is, should Parkinson's patients need more frequent eye exams compared to the general population?
So compared to the general population, Parkinson's will not be able to come for a follow-up frequently. You need to give them time. So that's why call them when required, because they'll have mobility issues, they'll have issues in motor issues, mobility issues. They will not be able to actually walk around freely like normal patients. So they might require help. And when they do that, it's not it's very difficult for them to visit the clinic. So what you can do is tell them to be healthy visually, I mean active physically. That's very important, because when you keep your physical fitness, your motor component also also is working. So probably when you actually give that as a push, then you can maintain it appropriately and then call the patient. But I would suggest you to call for 3 months maximum, not lesser than that, because definitely they're not able to come frequently because of their mobility issues.
All right. So our final question here is, what are the management options other than prisms for a patient with tremors and is not able to perform vision therapy?
Yeah, that's a good question, because this is a challenging one which we come across while giving the vision therapy, basically. So when there is when this occurs, you try with vision therapy. Try to keep hand stable, or even after they take medications, because their motor control gets better with medications. So tell them to come after they take the medications. If that is also not working, then probably give them a break, give them prisms initially, lower prisms to try with, and then if even if they are not able to do the vision therapy, then continue with prisms and wean off day by day, or you can actually switch over to prisms. This is just a trying a combination of what you do basically with the patient, either vision therapy or prisms. But if they are totally not able to do vision therapy, then I would recommend prisms. Otherwise, I would still do vision therapy with minimal amount of prisms, and then probably give prisms if they are not able to do completely.
Okay, so we have two more questions actually. What type of visual field defects, if any, are associated with Parkinson's disease?
So visual field effects, definitely, I mean, it's not a particular, I mean, presenting complaint as such. It can be associated with the associated comorbidities. Like, for example, if they get glaucoma, if they get any cataract issues, if they get any diabetic retinopathy issues, all the retinal issues then there is any comorbidity, you kind of end up in visual field defects. It's not solely because of the Parkinson's, basically. Even like if you have a cerebrovascular accident, you might end up with homonymous hemianopias. So it's much more to do as a comorbidity. But definitely in Parkinson's, we have seen retinal thinning, that is macular and nerve fiber layer thinning. So definitely that's there, but that doesn't actually make issues with visual fields. But overall, the peripheral vision is has a problem because they have the mobility issues and the oculomotor issues. They're not able to move their eyes around freely. So that's why they have issues with mobility.
So the last question is, any advice on vision therapy in Parkinson's patient with DBS? Any specific precautions required?
Sorry, I couldn't understand what is DBS.
I think they meant deep brain stimulation.
Stimulation therapy in patient.
Yeah, deep brain stimulation.
Deep brain stimulations. My apologies, I don't have much knowledge about this, but I don't think there's any precautions required because vision therapy does not actually worsen anything because it's to do just with oculomotor issues. And you just need to treat the oculomotor issues. Like, for example, if there is any convergence insufficiency, you're going to treat it with convergence exercises. You're not going to give any flickering lights or things like to actually I mean, if they have any motion sensitivity or if they have any light sensitivity, you're not going to induce anything like that. I don't think anything is required there.
Okay. So with that, we come to the end of our Q&A session. Thank you so much, Ms. Ayisha, for addressing all our questions. And a big thank you so much to our respected audience for attending and engaging in this important event. If this excited you to learn more about neuroscience, check out our exclusive course of Vision Science Academy, The Neuroscience of Vision. You can find the link to the course already provided in the chat box for your reference. Enroll today and get certified with a career certificate. Also, all premium members of Vision Science Academy will be receiving certificate with 2 knowledge points for attending this event. But if you are not a premium member and still want to receive a certificate, you can reach out to us and avail it by paying a small processing fee. So with this, we come to the end of our Vision Science talks for the month of April, conducted in relation to the Parkinson's Awareness Month and World Parkinson's Day, celebrated on the 11th of April every year, to amplify awareness and understanding of Parkinson's disease globally. A big thank you to Ms. Ayisha for taking out time from your busy schedule and joining us as a speaker of the event. I'm grateful to the audience for your active participation that has led to a successful conduction of this event. So I request you to please take a moment to fill out the feedback form provided in the chat box before leaving. Thank you once again and see you in our next event. Thank you so much.